for atrial fibrillation conversion is sometimes problematic, as we have to wait for the right level of anticoagulation. And I think this material coming from Germany will give us a new way for the patient's procedures.
Yeah. Well, ladies and gentlemen, I'd like to present the final study results of the ENSURE-AF trial to you. So these are my disclosures. So as a background, atrial fibrillation really is a very common disease, and currently actually guidelines recommend 3 weeks of therapeutic anticoagulation prior to cardioversion and continuation of anticoagulation for at least 4 weeks post-cardioversion. So this is very important really to reduce the risk of stroke in this setting. So vitamin K antagonists have traditionally been used as oral anticoagulants pericardioversion, but vitamin K antagonists really are associated with inter- and intra-patient variability, so it's very difficult to keep INR in the therapeutic range. And current data from post-hoc analyses of the 3 NOAC trials, as well as 1 prospective randomized trial, suggests that NOAC could be used as an alternative to vitamin K in this setting. However, the data on Edoxaban in this scenario are limited. So for that reason, we performed a prospective randomized international trial to assess the efficacy and safety of Edoxaban compared to the best possible conventional therapy consisting of enoxaparin plus warfarin in patients with non-valvular atrial fibrillation undergoing electrical cardioversion. So the patient were then randomized and stratified in accordance to the current practice in the different institutions. So a TEE, a transesophageal echo-guided approach was allowed, and also the conservative strategy of a non-TE guided approach. Randomization occurred to Edoxaban, 60 milligram once a day, and the dose was reduced to 30 milligrams if body weight was low, kidney function was below 50 milliliter per minute, or PGP inhibitor was administered concomitantly. The control arm was consisting of enoxaparin, and enoxaparin was administered in those patients where the INR was below 2. So enoxaparin was only administered for the short period of time until INR was above 2 to make sure that anticoagulation was adequate. And that was done in both treatment arms, dealing with enoxaparin and warfarin. Duration of follow-up was 28 days and additional 30 days with regard to safety assessment. So these are the primary efficacy outcomes. So the efficacy outcomes consisted of the composite of systemic embolism, stroke, myocardial infarction, and cardiovascular mortality. And you can see, and this I think is important, that the time in therapeutic range after INR level was above 2 was 70.8%, so a very well controlled warfarin arm. And you can see that numerically the numbers are low, and there's a trend towards reduced episodes of ischemic events regardless of the used strategy, and the TE guided as well as non-TE guided strategy using Edoxaban. However, these results were not significant. Oops. What about the safety issues? And these slides summarizes major bleeding events as well as clinically relevant non-major bleeding events. And you can see that overall the numbers were low, 16 versus 11 events in the 2 treatment arms. Major bleeding occurred in 3 patients in the Edoxaban arm versus 5 in the conventional arm. And overall, any bleeding event was 32 versus 35. So there was no hint towards an increase in any of these arms. The net clinical outcome was calculated, and that encompassed the ischemic endpoints plus major bleeding events. And there was also just numerically a trend towards a better outcome in the Edoxaban treated patients, although not significant. In addition, the kidney function to various classes had no effect at the initial net clinical outcome values. So in conclusion, the ENSURE-AF trial, with more than 2,000 patients randomized in that trial, it's the largest prospective trial to this date, dealing with this clinical setting of electrical cardioversion and analyzing the effect of Edoxaban. So overall, the rates of composite primary efficacy endpoint and major bleeding event as well as clinically relevant non-major bleeding event were similar in both treatment arms, irrespective of the TE-guided strategy. So the net clinical benefit was numerically lower, but not significantly different in the two treatment arms. So the Edoxaban appears to be effective and safe alternative in this scenario, dealing with the pericardial and pericardioversion setting in patients with non-valvular atrial fibrillation, and it allows actually a very rapid onset of cardioversion after 2 hours of the first administration of Edoxaban. I'd like to highlight that our results will also be released today. They have been accepted in the Lancet, and publication, the online publication, will be available during this morning. Thank you.
Thank you very much for this presentation. Questions from the floor? Yes?
This is Crystal Fenn with MedPage Today. My question is, how much of a difference would it make clinically for you to have that time difference that you're saying that Edoxaban is very rapid?
Well, there are, of course, two treatment strategies. So a TE-guided approach really allows cardioversion within hours or at least 1 or 2 days after the patient really presents, and the conservative arm requires a pre-treatment phase of 21 days. So the strategy makes a substantial impact. On the other hand, you need to have an anticoagulant on board prior to the procedure, and due to the fact that Edoxaban kicks in within 2 hours, you can do the procedure right after 2 hours after the first initiation of therapy, which is just by warfarin definitely not possible, and therefore, of course, you need to have heparin also.
Next question at the front line here.
Steve Stiles, theheart.org, Medscape Cardiology. Can you discuss a little bit about the interplay between your findings and the use of TEE? Does this have an impact on whether discretion would favor TE or not TE in particular patients, or is it just that you need to start at 3 weeks earlier if it's TEE as opposed to shorter time interval?
Yeah, well, in our study, actually, the number of patients received TE and non-TE guided strategy were really balanced, so almost 50% of the patients were in both groups, and it really depends also on the practice, the current practice in the different countries. So there are tremendous differences within different countries. So in the northern countries in Europe, actually, TE is usually performed to have a rapid mode of therapy in that patient, whereas in other countries, really the pre-treatment phase is a first-line therapy, so really patients do not receive TE at all, so they really require 21 days of adequate anticoagulation.
In this study, how were patients chosen for TE? Was it up to the discretion of the investigator?
Yes, it was up to the discretion of the local investigator to keep them comfortable to do what their current practice is.
In current practice, how long before cardioversion does one start warfarin with enoxaparin bridging or with some kind of bridging?
Well, usually it's if you want to do it immediately after, for example, a TE, then you start the first injection of enoxaparin or other types of heparin right before the procedure, and then you can go ahead, do the cardioversion, and then you continue enoxaparin until warfarin or another vitamin K antagonist has reached really the therapeutic range of 2.0 or above.
These are newly diagnosed atrial fibs, so they would not have been on anticoagulants. When would you start anticoagulation?
Yes. We have included patients which were naive to anticoagulants, and about these were 27% of the patients included in the trial, and the remaining actually were experienced.
Yes, Professor Huber.
Dr. Goette, could you summarize which patients should receive the lower dosage of edoxaparin, and is the lower doses as safe as 60 milligrams with respect to the outcome data?
Yes, actually the study design was equal to the calculation and also recommendation used in the large ENGAGE trial. So all patients were randomized in the Edoxaban to 60 milligram Edoxaban a day, but if body weight was less than 60 kilogram, creatinine clearance was below 50 but above 15 milliliter per minute, or the concomitant use of a PGP inhibitor, then we had to reduce the dose to 30 milligram. However, the outcome, the overall outcome, was not different if we compare 60 milligram strategy to those patients who need to be dose reduced.
A final question, yes?
Good morning, Melissa Walton, ShirleyTheHeart.org, Medscape Cardiology. Any projected cost savings with using Edoxaban? I don't know what your habits are in Europe, but you know we wind up keeping these patients in the hospital in the U.S. until we achieve a target INR instead of bridging at home with Lovenox often.
Yes.
So, any thoughts there?
Well, that's a very important question, and I think our strategy really implies that it's very convenient and can be done very fast. We are right now in the process really to calculate the impact on health costs and economy in this specific situation. So far, we do not have final data yet.
Thank you very much. Now,